G'day. Welcome to Emergency Medicine Topics in One Coffee. I'm Alan Giles, an emergency physician, and today we're going to talk about acute appendicitis in adults. Now, what I want to focus on is how to decrease the chance of misdiagnosing appendicitis and also on the role of CT and ultrasound. Now, I've got a particular interest in this topic as I ruptured my appendix only a couple of weeks ago following an atypical presentation. Thanks for asking. I'm okay now.
We tend to think of appendicitis as a young person's disease, as 70% of presentations are in patients under the age of 30 years. But it can occur at any age. For example, a 109-year-old lady in Japan had a successful appendicectomy in 2012. So to start, let's review the pathophysiology with thanks to osmosis.org.
Since the appendix is a hollow tube, the most common cause of inflammation is something getting stuck in or obstructing that tube, like a fecalith, which is a hardened lump of fecal matter that finds its way into the lumen of the appendix and wedges itself there. Now the appendix is plugged up, right? Well, the intestinal lumen, including the appendix, is always secreting mucus and fluids from its mucosa to keep pathogens from entering the bloodstream and also keep the tissue moist. Even when it's plugged, the appendix just keeps secreting as usual. When this happens, fluid and mucus builds up, which increases the pressure in the appendix. And just like when you fill up a water balloon, it gets bigger and physically pushes on the afferent visceral nerve fibers nearby, causing abdominal pain. Along with that, the flora and bacteria in the gut are now trapped, right? And intestinal bacteria that are usually kept in check in the gut, like E. coli and Bacteroides fragilis, are now free to multiply. And this causes the immune system to call up white blood cells, and pus starts to accumulate in the appendix. This activation of the immune system can be seen in the lab as an increase in the serum white blood cell count. Patients might also develop a fever in response to the infection, which in combination with right lower quadrant abdominal pain at the point roughly where the appendix is, known as the McBurney's point, is a super important sign for identifying appendicitis. Also, along with the fever, other classic symptoms include nausea and vomiting. Now, if that obstruction persists, the pressure in the appendix increases even more. At a certain point, as the pressure keeps going and it continues to swell up, it pushes and compresses the small blood vessels that supply the appendix with blood and oxygen. Without oxygen, the cells in the walls of the appendix become ischemic and eventually die. Since these cells were responsible for secreting mucus and keeping bacteria out, now the growing colony of bacteria can invade the wall of the appendix. As more cells die, the appendiceal wall becomes weaker and weaker, and for a small proportion of patients, it gets weaker to the point where the appendix ruptures.
Makes sense? And we all know the classical textbook presentation of acute appendicitis. Young person gets nausea, anorexia, and mid-abdominal discomfort. Progresses to pain in the right iliac fossa, and that pain's exacerbated by jumping or hitting bumps in the car. And they may have a fever and occasionally diarrhea or vomiting. And the examination again simple. Tender in the right iliac fossa with guarding or rebound from local peritoneal irritation at McBurney's point. The bowel sounds, well, they're decreased, and if you're thinking a bit laterally, you might find a positive psoas or obturator sign with an atypically positioned appendix. You take blood and find the white cells are elevated. Keep them nil by mouth, IV fluids, IV analgesia, and call the surgeon. Next patient. And sure, if you have a patient with that sort of history and examination, it is pretty basic. But however, the reality is that the presentation is often much less straightforward. The classic history occurs in only about 60% of patients. And 2017 data suggests that we miss about 6%, sending them home only to have them bounce back with more severe disease. And in the USA, a delayed diagnosis of appendicitis is amongst the top 3 malpractice claims. One reason for non-classical clinical presentations is the variable position of the appendix. A retrocecal appendix often doesn't get peritonism. A pelvic appendix can cause urinary symptoms, suprapubic pain and pyuria, and this is what happened in my case. And if your appendix is parailial, you may get diarrhea. And you can see from this table I've taken from EMDoc's appendicitis review that the classical symptoms and signs are variable in their sensitivity and specificity. And what about the white cell count? Well, in a review of 1,919 patients with appendicitis, a normal white cell count was seen in 11% of patients. There was no difference in age, fever, gender, or severity of disease in the patients with a normal white cell count compared with those with an elevated white cell count with a P greater than 0.05. And the proportion of gangrenous and perforated appendicitis in the patients with a normal white cell count was the same as in patients with an elevated white cell count. And what about CRP? Useful or CRAP? It's a similar story to the white cell count. Look, even with ruptured appendices, it's not uncommonly normal. I mean, it's normally elevated, but it may be normal. So you can see that you can't rule out appendicitis with a particular symptom, sign, or blood test. The best answer we have to assist your clinical judgment is to use a scoring system and choose your imaging wisely. Now, prior to the advent of a prediction scoring system and the use of CT, clinical impression alone yielded a negative appendicectomy rate of about between 20 and 40% and a diagnostic accuracy of 58 to 92%. Judicious incorporation of blood tests, imaging, and prediction scoring systems has brought the negative appendicectomy rate to below 2%. But of course, we're still sending home over 6% who bounce right back. Okay, scoring systems. The two used in adults, Alvarado and the AIR, or Appendicitis Inflammatory Score. Both put the patient into low, intermediate, and high-risk groups. AIR uses a blood test, CRP, as part of the score, and has been shown to be superior for identifying high-risk patients. If you are low risk, you're considered safe to go home. High risk, you go to OT, and intermediate risk means you need further investigation. Interestingly, if I used either of these two scores on my own presentation, I would have come up on both as being low risk and be allowed to go home for outpatient follow-up. So be a little bit careful. Now I want to look at imaging, which, as I mentioned before, you'll be doing for intermediate risk patients and may use in patients with a low risk score, but who are still, clinically concerned. Firstly, ultrasound. Very useful in young, thin patients. And with a good ultrasonographer, it's reliable to see an abnormal appendix, that is an aperistaltic blind tubular structure greater than 6 millimeters diameter that's not compressible with the ultrasound probe. You may see an appendolith with posterior acoustic shadowing, as you can see here. Or you may see fluid around the appendix, an example you can see now on the screen. However, finding a normal appendix can be problematic. So it's harder to rule appendicitis out. It has a sensitivity of only about 63%. This is especially true in obese patients. Now CT, highly sensitive, 94 to 98%, and specific up to 97%. You can see dilation of the appendix, wall thickening, fat stranding, appendoliths, abscesses, air in the wall. What's not to love? And here are some examples, starting with my own CT and then a few from Radiopedia. Of course, you're looking at about 10 millisieverts of radiation, the effect of which is greater in a younger patient. But in the intermediate risk adult patient, you can start with an ultrasound, but if it's negative or inconclusive, just go ahead and get the CT done. So what are the take-home messages? Well, 1, always be suspicious of atypical presentations and try to avoid getting cognitively fixed on what a typical appendicitis patient looks like. 2, use a scoring system, but don't be a slave to it. 3, sure, use ultrasound, but in the older patient, or if the ultrasound is inconclusive, just do a CT scan. 4, in a hot appendix, don't muck around, call the surgeon early.
Well, I think that'll just about do for acute appendicitis in adults in one coffee. Look forward to seeing you all again. Stay well, and I'll catch you later. Cheers.